All right. Welcome everyone to this week's Virtual Global Spine Conference. I'm Andy Grossbach. For those that don't know me, I'm Associate Clinical Professor at Ohio State University. I'm Residency Program Director here and the Spine Fellowship Director here. This evening or this morning or wherever you're from, I'm going to be giving a talk on preoperative planning and patient-specific rods and adult spinal deformity. So just a brief overview. I've given a talk on this before. It's been a few years. So I've been using this software planning software for a while, the patient-specific rods, and so I can kind of talk about what I think they're helpful for, and shortcomings, and I think future directions. Happy to answer any questions people have. So feel free to speak up or leave a comment. Here's my disclosures. So we'll get into cases here. First case, 52-year-old female, presents with several years of progressive axial back pain, difficulty maintaining standing posture, has done all the conservative modalities, physical therapy, steroid injections, RFAs, radiofrequency ablations. And here's her exam. She's intact, but she does have a left-leaning posture. And so here's our imaging. So on the left here, we have a sagittal view. Not terrible. She maybe has a little kyphosis at thoracolumbar junction, but she's not bad here. The AP view here, so you can see she's leaning to the left, so her CSBL is off, and she has this double major, this thoracolumbar curve. And so you can imagine just looking at what particularly L4-5 looks like there. She has a lot of foraminal stenosis at her fractional curve, and so that's what I'm trying to show here on this parasagittal MRI scan. So you can see that L4 foramen is pretty tight, L5 foramen is pretty tight. Just getting a lot of radicular symptoms from that. So when I look at cases like this, I mean, first I try not to operate. We try all the other things first. But when I look at this top-down stenosis foraminally, I don't have a great option besides doing an interbody fusion at that level, which of course is then going to change the fractional curve and potentially throw off her CSBL the opposite direction. I talked to some of my colleagues that do some endoscopic work. There's maybe a possibility in the future that as people get better and better at endoscopic things, and maybe some of you out there now would approach this endoscopically. But I think with the combination of difficulty standing upright with the radicular symptoms, then we talk fusion options. My big worry here, and the reason I showed this case, is because obviously to correct this coronal deformity is going to require multiple osteotomies, posterior column osteotomies. And what I don't want to do is lay this patient on the table, do a bunch of SPOs, correct the coronal deformity, and then cause a hyperlordosis in the lumbar spine. I've done that before. It's a recipe for disaster. Patient stands up, they're hyperlordotic, then they're going to PJK, PJF very quickly. You're going to have to go and revise and get things back into alignment. And so that's my biggest worry here. And so here's our plan. So we're going to address both curves and correct a little bit of the kyphosis at the thoracolumbar junction. But largely, I want to keep this patient in the sagittal balance that they have. And here's when we execute it. And so this case in particular, patient lays on a Jackson frame. You cut the SPOs to get the coronal correction. And that patient is laying hyperlordotic. And so with the patient-specific rods, you can bring that rod in and say, wow, it's if I did it the way I used to do it, bend that rod down into that lordosis, they're going to be hyperlordotic and they're going to PJK or PJF. And so you can actually use reduction towers just to pull that patient's spine that's now very mobile, just right up to the rod, lock them in place, and you're not going to overcorrect. And so that's kind of why I showed this case where I think the patient-specific rods are very helpful, is to avoid overcorrection. Of course, when I started using these rods in the software planning, I mainly did it for the planning software and the data collection. I thought, we can all bend a rod, I don't need, someone to bend the rod for me, because there is a cost that comes with it. But I think particularly in cases like this, it's very helpful to know that like I'm going to get the correction I planned. I'm not going to get, overcorrect. I'm not going to undercorrect. It kind of verifies that, hey, we got what we're going to get. And when that patient stands up, they're gonna stand balanced. Next case here, this is a 62-year-old female, progressive axial back pain, radiating leg pain. She has some lower extremity numbness and weakness. She's had several falls, uses a wheelchair for long distances. She's tried physical therapy. She does have a history of an L5S1 TLIF done in 2012. She also has a history of a back pump placement. So her exam, she's intact in the uppers and the lower extremities, diffusely 4 out of 5. She has some 3 out of 5 dorsiflexion EHL on the right, so a little bit of right foot drop, some diminished sensation in the legs. And I showed this, not that this has anything to do with the case, but I just thought this was interesting. So here's x-rays that they got every 6 months for her back pump, but you happen to be able to see the lumbar spine in them. So on the left there, you can see her L5S1 TLIF. It's been in there for a long time. And she's pretty straight. Next one over to the right, starting to get some degenerative disc disease, but not horrible. Next one to the right, now she's starting to get a little coronal decompensation. And then 6 months later, she's really tipped over. So you can kind of see this progression of what's happening above her prior construct. And again, this was 2012 was her original fusion. So this was years and years down the road that she started to get this decompensation. This is what her CT and her MRI look like. So on the left, you can see these disc spaces are pretty shot. They're very moth-eaten. Some vacuum discs at L3-4, L2-3, L4-5, bone on bone. In the middle there, you can see the L4-5 foramen, or what used to be the foramen. Then on the right there, you can see, she's a ton of foraminal stenosis at this curve. And here's her x-rays and her plan. And so on the left there, sagittal, you can see she's actually kyphotic in the lumbar spine. One important note is to look at her thoracic spine. So she's flattening that thoracic spine. And so people compensate for loss of lumbar lordosis in a couple ways. One is, of course, to retrovert their pelvis, so increase their pelvic tilt. The other is to flatten the thoracic spine. So you take that kyphosis out of the thoracic spine to try and stand up straighter. I'm okay at visualizing some things. I can look at a pedicle and say, if I'm going to do a PSO here, how many degrees am I going to get? I'm okay at SPOs if I'm going to do multiple, like in this case, uh, knowing about how much I'm going to get at each SPO. What I'm really not good at is knowing what the thoracic spine is going to do. And so sometimes the software can be helpful to know when that patient does not remove that thoracic kyphosis anymore, when they relax that thoracic spine and their kyphosis comes back, what's that going to do to the SVA? What's that going to do to the global alignment? And so here, the software is anticipating what's going to happen when they relax that thoracic spine and when they get that thoracic kyphosis back, the normal thoracic kyphosis, what things are going to look like. Because if you don't judge that well, you could either undercorrect or overcorrect somebody, and globally they'll be off. So here's our plan in the middle. We plan to do it with all posterior column osteotomies. Um, I was hoping to get an interbody in at L4-5, but I wasn't sure if I was going to be able to, so I planned it without. And then on the right here, you can see coronally. Not terrible, but she's definitely got some curve in the lumbar spine there. And then this is post-op. And so on the left, coronal, you can see balance is better. And then sagittally, you can see preoperative or plan, and then postoperative. And I hope you can see here that that algorithm that planned that thoracic kyphosis coming back was pretty accurate. And so you can see she's kind of you know kind of aligned her thoracic spine the way it wants to be. And we can see that reflected in the numbers. And so I do like this platform, or any preoperative platform that helps us collect preoperative data, what our plan is, and then postoperative data, because most of the literature right now in the deformity world is patient comes in, they're bad, their SVA is high, their pelvic tilt's high, their PIL mismatch is off, and then you do surgery and those are better. But are they what you planned? Are they enough better? Are they, did we get the correction that we wanted to? This makes you prove it. You have a plan, it saves those numbers, and then you see, did you meet the plan or not? And then you follow up at each time point, and they do the calculations. You can see, do we maintain that correction? Is it durable? Does that go away? Or if the PJK, does their pelvic tilt go up? Does their SVA go up? 6 months or a year. So looking at lordosis here. Um, so on the top here, we have lumbar lordosis, and the bottom PIL mismatch. So first is a preoperative visit, so she had 4 degrees of lordosis. The next number over, 40, that was our plan. We planned to get her to 40 degrees of lordosis. And then at our first follow-up here, 47 degrees, so a little more than what we planned, but that's okay. And then our PIL mismatch took it from 53. 17 was our plan. We actually got it to 11, so pretty close to that goal of 10. And then I think more interestingly is what happened to her thoracic kyphosis. So first number there, -1. So she's actually 1 degree lordotic in her thoracic spine from T4 to T12. And then you can see our plan with that relaxation of the thoracic kyphosis, 27 degrees, and she was about 29 degrees. So very accurate in what's going to happen, reciprocal changes in the thoracic spine after our surgery. Next case here. So this is a 54-year-old gentleman presented to clinic with progressive back pain, difficulty standing upright. Has been progressive for a couple of years. Has a history of MS, back of him pump placed as well for that. And here's his exam. He does have some, trace weakness on the right upper and lower extremity. It's not related to his spine. This is related to his MS. Fortunately, his MS has been under pretty good control. So he does have that kind of, baseline weakness, but he's not having a lot of, relapses and new symptoms. His gait is slow and intelligent. He's very kyphotic and he leans to the right. And so this is him in clinic here. So this is how he stands. This is a difficult way to live life. And you can, don't need Scoliosis x-rays to know that this is a global problem. And so, very debilitating things are, having a very positive SVA, and then having, the inability to maintain a horizontal gaze. So if you're living life just staring at the floor, that makes things very difficult. Here's his Scoliosis x-rays and his numbers. So you can see his pelvic tilt's a little high at 31. His PIL mismatch is a little high at 27. His SVA is almost 12 centimeters. And then his coronal balance is off about 22 centimeters to the right. So when you look at this, it's going to be a big surgery if you're going to offer surgery. Obviously, they have to be healthy enough. But in someone that's relatively young, stable MS, healthy otherwise, I think you can talk about doing something to correct this. It's tough to know where to start on something like this. Are we going to need 3-column osteotomies? Are we going to need one in the cervical thoracic junction, one in the lumbar spine? Can we get by with posterior column osteotomies? I like to whenever I can. But sometimes when you're starting from something that's going to be a big surgery, some planning software can be very helpful, because they can give you different looks and say, you know what, this is what it's going to look like, and you can have them give you different options. And so in the middle here is a plan that we ultimately went with, just relying on posterior column osteotomies. And looking at them sagittally might not be perfect after this, but sometimes you'd rather undercorrect than overcorrect. And so here's what he looked like, after surgery. So this is a big surgery, obviously, C2 to pelvis. On the right there, you can see his post-op, and the reason I like to show this is this is the first time I've had a C2 to pelvis where I got one rod run the whole way. So on the right, that rod is one patient-specific rod from C2 all the way down. On the left, you can see at the cervical thoracic junction, we actually, cut the rod and had some offset connectors because our T1 screw and T2 screws were the heads were very lateral, so the rod run didn't quite line up. But I was pretty impressed that we were able to get at least one rod that whole way. And then here's him sagittally, and so again, not perfect, um, but certainly better than what he was. And here's him at his 2-year follow-up with me in clinic here. Again, not perfect alignment, but able to maintain a horizontal gaze and much happier than staring at his shoes all day. Next case. So this one I show because, up until now, all the cases were nice to have. Preoperative planning made my life easier. I didn't have to put as much time and effort into doing the measurements myself. Patient-specific rods, nice to have. Didn't absolutely need them. This is a case that I don't think I could have done without the patient-specific rods. Um, so this is an 18-year-old male presents with worsening scoliosis. So his history of NF type 1. He's had several surgeries, several corrections of his scoliosis over the years since he's a teenager, young teenager. He's neurologically intact. And so I'll take you through a few of them here. So initially, he had some growing rods placed for his scoliosis. You can see those on the left, the sagittal and the AP X-rays. Those are taken out, and you can see what happened. So he kyphoses over, and you can see his upper thoracic scoliosis is pretty terrible on the right there. So they take him back and do a screw and a hook hybrid construct and get him better on the left here. And then you can see what happens on the right. He starts to kyphose over more, and this hardware becomes very prominent, starts to poke out of his skin. He's very, very small. You can see on the x-rays he's not real large. So then they go up to the cervical spine. So you can see here in the cervical spine, 3-5 rods connecting to 5-5 rods in the thoracolumbar spine. In the middle there, you can see the connection between the rods. Actually, I think the rods snapped on one side and the connection gave way on the other side. And then on the right here, you can see on the top right, one rod broke, one rod became disconnected right at that apex of that kyphosis. Bottom left, took them back, revised. There's this time a VCR, so you can see a cage in there. But you can look at these 3-5 rods making a curve that's like 90 degrees, and you can know that it's not going to last. And so you can see on the right, then rods broke again, and scoliosis comes back, kyphosis comes back. So this is what we plan for him. So of course, going back in there and doing the same thing is probably not going to be successful. It's very difficult to bend a 5-5 rod to 90 degrees. One, it's hard to do, and two, you fatigue that metal a lot by overbending it. If you take a 3-5 rod and you have it bent 90 degrees, that's not a strong rod. It's failed multiple times now. And so you can see in the middle here, here's our plan. And so we plan to get this kyphosis better, and we have the 5-5 rod crossing where the apex of that kyphosis is. As you can see on the right here, the execution of our plan. And so fortunately for us, the cervical spine had fused solid. So I had multiple points of fixation in the cervical spine that was fused. And I could use these rods to cantilever basically that kyphosis to take that kyphosis out. So you can see his post-op x-rays here. And then in the AP view here. So able to not only correct the kyphosis, but the scoliosis. And then at the apex of that curve, you can see now we have, 5-5 rods. You look where that VCR cage is on the right. We have, now 3 5-5 rods across that. So this is going to be much more robust than having, 2 3-5 rods across the apex of that curve. So he's a little over 2 years out now, I believe, doing very well. And so so far, knock on wood, has held up much longer than his prior constructs. Last case here. So this is a 53-year-old female, progressive back and leg pain, history of osteoporosis. Intact on exam, a little hyporeflexic and a little slow and intelligent gait. But here's her x-rays here. And so this is similar to our first case, where we had, a big, coronal curve, at the fractional curve, a lot of foraminal stenosis, also at the apex of her lumbar curve, but sagittally not awful. And so the reason I showed this case is because these rods then help us dial in, like, where do we want to add lordosis, where do we want to improve kyphosis in the thoracolumbar spine. So here I want to do it maybe not between L4 and S1, where a lot of times we're really trying to crank in a lot of lordosis, but here I want to take a little bit of that kyphosis out of the thoracolumbar junction. And so, I don't have to put a whole lot of thought into how to do that. This tells us, we're going to cut some SPOs there, and that patient-specific rod is going to, basically, hopefully drop right into the lumbar spine, which is already, adequately lordotic between L4 and S1. But we're also going to be able to take some of that kyphosis out at the thoracolumbar junction. And so this is her post-op X-rays after, and so able to get again a lot of osteotomies to correct this coronal deformity, but we can really dial in where we want that lordosis correction, where we want to maintain our normal lordosis and not get hyperlordosis laying on an open Jackson frame and really have them sink down into the bed with a lot of posterior column work. So to wrap up here, preoperative planning in adult deformity surgery, planning is of the utmost importance. How you do it, that's up to you. You do your own measurements. You have software that helps you. The fact that you're planning is important. I think it is important to keep track of what you plan, even if you do it on your own. If I just have a plan in my head, I think I'm going to get this many degrees, and I do the surgery, but I don't have that plan written down anywhere. Then I don't know if I achieve my plan or not. And if that patient fails, if they get PJK, if they get a rod fracture, if they get PJF, if we're going back to surgery, I don't know if it's because my plan was wrong or because I didn't execute my plan. So I think it's important, regardless of how you do it, to keep track of what you're trying to achieve, and then seeing, did I hit that? And if the patient fails, is it because my plan was wrong or because I didn't execute my plan? Patient-specific rods are helpful, but they're not foolproof. You can't just lay them in there and just reduce on everything. You're going to start pulling out screws, and it's not going to be good. And they come at a cost. They are more expensive than off-the-shelf rods. But I do think they can help you confirm your intended correction, and I think they can really help you prevent overcorrection. You can still execute a faulty plan. So this is where I think it's very important to be self-aware, look back, see if patient fails, why was that? Nobody's been able to eliminate PJK or PJF. Still happens to me more than I care to admit. So I think it's important to be reflective on that, and always striving to improve and get better. So I'm going to stop there. Dr. Selby, I see you just hopped on. Answer any questions anyone has.
Hey,
Mike, are you
Andrew.
using any? How are
I'm
you?
here. Hey, I'm good. I'm good. Hey,
Good.
that was good. I was there for a lot of
Oh,
that.
good, good.
Hey, I was going to ask you, I think our philosophies are similar on a lot of stuff and a little different at times as well. Some of those cases, like the neuromuscular one, they're really challenging to get to fuse. A lot of those patients have really poor bone biology, etc. And they are, a little bit, how can I put it? Sorry, doctor driving past very loud in the car park.
No worries.
They're ones that I think are, in my hands getting antibodies at multiple levels for fusion rates. But, are you using BMP for these cases? Because I think that's something a lot of people, maybe outside the US don't appreciate is that how good BMP is for a lot of these cases. And
For sure. Yep.
yeah,
Yep. So I think we had talked maybe a couple months ago at one of these talks. Um, it's important, and so it's an important point because obviously we want these patients to fuse, and um, I am very fortunate that I do have access to BMP, and in a patient like that, um, neuromuscular. I think I have two main points for him. One is I absolutely use BMP for that. And so if you're somewhere where you don't have access to BMP, um, then multiple interbodies is probably needed to get that patient to fuse. Because neuromuscular cases in general are very difficult to get to fuse. Um, so I think that it's a combination of three things. It's like multi-rod constructs can make things, much more rigid and have, less rod fractures. I think patient-specific rods in general are stiffer. And so you're not notching the rod as much and you're not fatiguing the metal as much. So I've had better success with less rod fractures, particularly in my osteotomy sites and my lumbosacral junction. That being said, they are stiffer, and so that is not necessarily better for your PJK rates. And so, I don't think that so far I've been able to move the needle in the right direction for my PJK and my PJF using patient-specific rods. So I think I've needed probably less interbody support with patient-specific rods and the multi-rod constructs. But I am using BMP. If you're not, then I think multiple interbodies are likely needed in addition to, multi-rod constructs or maybe patient-specific rod constructs. Um, the other thing is, I got asked this recently on how do you decide for these patients with, neuromuscular curves, like who's a candidate for surgery? Early in my career, I was giving talks on Parkinson's and scoliosis and camptocormia and Pisa syndrome, and I had someone that was senior to me come up very early and was like, "Hey, you might not want to give those talks because everyone's going to be sending you those patients because they're very difficult because they don't fuse and they do have a high complication rate. Um, so certainly if someone has uh, a progressive disease without a treatment, that's someone that I'm much more hesitant to jump into a large surgery for. This guy that had the MS, his last flare up was years ago, and so he was not this relapsing and just stepwise decline from his MS. He was very stable. He had a little trace weakness left over from it, but he was not having a very fast progressive course, and so that made me much more comfortable, offering a large surgical fusion for him. But I think your point about the interbody support and BMP is well taken. It's an excellent point. Are you using any
yes.
planning software or anything right now?
Oh, Andrew, yeah, I do. Not every case. So,
Yep.
I mean, I'm lucky enough to have like some nice pre-contoured rods that are pretty much, a normal PI, nice shape that I've been using for years. But they're not for everyone, right? And so I've been doing a bit of the Uni D planning, and I've done a SMAO case as well. So I'm using bits and pieces of each of the companies offering this technology. I do think there's a real advantage in using it almost like a template.
Hmm.
Um, and look, I mean, the thing for me is that I still do multiple interbodies. So I've often dialed in that L4 to S1 already with an ALIF. So then for me, the advantage of the rod is actually having basically to not worry about over, or under bending it, and that more of the biomechanics of the rod being stronger from me not fiddling with it and bending it and changing it and cutting it all in the OR. I found they fit pretty well most of the time, but I've always found that I'm bending down a little bit more proximally at the top because I like to never have any tension on my top screws.
I do the same thing.
Yeah.
Yeah,
So
I like, if the rod's at all proud over the screws, I'm in situ bending that like right down into the screw heads. I don't want reduction towers. I don't want anything on my top levels. I just want to set the
yeah,
caps in there and that's it. So I'm for the most part they fit pretty well, but I am in situ bending them into my last, couple of screws approximately. Yep.
yeah. All right. Well, it's good, Andrew. Thank you very much.
Yeah, absolutely. Any other questions, comments?
Yeah, I got a question for you, Andrew.
Sure.
You heading to SRS?
I'm not. I think
Oh,
one of my partners, Steve Villian, is probably going to be there.
yeah,
But
no
yeah,
problems.
I'm not this year. You're going to be there, I take it?
I'm going to be there just for a day and a half. So yeah,
Yeah.
should be good.
Yeah. Good. Good. I'll be at, I think the rest of the year, CNS, probably be at CSRS.
Yeah, a
But yeah.
few other ones. Excellent.
Yep. Awesome. Well, as one of my mentors once said, the best hour-long talk is a half-hour-long talk. So give everyone some time here this evening. All right.
Thanks, Andrew.
Thanks, everyone. We'll see ya.